Hi, it's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question from one of our readers, and the question last week was about tracheostomy in children. You can check out last week's question by clicking on the link below this video. In today's episode of Your Questions Answered, I want to answer a question from one of my clients, Joan, as part of my one-on-one consulting and advocacy service. Joan's dad is in ICU and is not as responsive as before. Joan is asking if her dad is being sedated by the medication that the ICU team is giving him. So today's question is, my dad is less responsive in ICU. Is he being sedated by the medication that the ICU team is giving him? So Joan writes, "Dear Patrick, I tried to make this short, but I couldn't. I did leave a lot out, however. It is 2 months now after my 71-year-old father had a stroke. He was in ICU for about 2 weeks after a procedure for decompression, and he has been ventilated and with a nasogastric feeding tube ever since. He contracted pneumonia twice and another infectious disease. He had a tracheostomy. The ICU unit had to be cleared because everybody on the floor contracted the same infection. Antibiotic resistant but dormant. He spent about 2 weeks in the infectious disease unit, which was similar to the ICU. He slept a lot and was unresponsive a lot, but then he would wake up and could understand everything and seemed like the same person. He could follow all commands, and he put up a big struggle when the nasogastric tube needed to be readjusted. He was expressive and understood everything, even though he couldn't talk or sit or anything like that. He was very weak from fighting off the infections, the antibiotics, the pneumonias, the fever, etc. After 1 month, he went 2 days without a fever and was transferred to a geriatric center to the unit that specializes in respiratory rehabilitation. This place has an excellent reputation and good success with respiratory rehabilitation. There is a stroke rehabilitation unit in this same center, however, he was not transferred there. The ride in the ambulance took a toll on him, and he arrived with a fever that lasted quite a while, and he was given more antibiotics. Finally, when the fever went away, they began to work on his breathing. This is the background. My current concern as of the last 2 to 3 weeks is that he seems much less alert and responsive now to me than he did before. He's not responsive most of the time, at least not when I am there. He is put in a chair. There are days where he breathes on his own for about 12 hours at a time, which looks very painful, by the way. Cognitively, he seems to be doing much worse to me than before, and also at least one doctor at this center gave him a very low score in comparison to the assessment they gave him in the hospital. At first I was told it was the fatigue from breathing and the fever and all these other things, but could it be the medications that they started giving him when he arrived here? I spoke to a relative who is a neurosurgeon, and he says he needs a CT scan to determine if something has changed, but they don't offer that at this center, and his other family members are against transferring him. They are on a different branch of the family than the neurosurgeon. When he was in the hospital before, he did contract multiple dangerous infections, and the ambulance ride was hard on him. For now, I would rather ask if the medications might be the culprit. So finally, let me get to the point. The doctors reluctantly agreed to remove Depilept 500 milligrams twice a day after being very dismissive about my request. This was about 10 days ago. However, it turns out they didn't remove it. They only told us they did, and today his wife confronted them about it. So now they have said they will remove the Depilept against their own better judgment, and they will reduce the dose by half for the first 2 days and then stop it completely after another 2 days. I am very concerned that this is a very quick taper. 4 days when he was now being taken Depilept for almost a month, since October the 26th. At first they gave him 300 milligrams twice a day, and then they upped the dose Also, as you can see, the communication with the doctors at the center with our family is not the best, and also I am clashing with family members as well as about how to approach things. However, one thing that my family members and I agree on is that the medication might be sedating him. The biggest concern is this Depilept. And now, if the doctors really do remove the Depilept this time, I am very worried about this short 4-day schedule. Isn't it important to taper off more slowly? In the hospital where he was for the first month, I don't think they gave him any medications other than the antibiotics. I will find out for sure. They said they gave him Depilept to stop his trembling, according to other family members. I didn't hear it from them myself. If that's true, I don't understand why that would matter in this situation. They didn't say it was to prevent seizures or anything like that, though I do want to speak to them myself about this. Thank you again sincerely, and wishing you a great day, from Joan. Hi Joan, and thank you for writing in, and thank you for being a client. Joan, is there a history of seizures? Joan writes back, hi Patrick, thank you for your reply. No, he had a mini stroke a few years ago which left no effects and otherwise seemed very healthy, though he never went to the doctor. From Joan. Here is my response. Hi Joan, if there is no history of seizures, he shouldn't be on Depilept in the first place. This is from Wikipedia here. Valproate, VPA, and its valproic acid, sodium valproate, and valproate semi-sodium forms are medications primarily used to treat epilepsy and bipolar disorders and to prevent migraine headaches. They are useful for the prevention of seizures in those with absent seizures, partial seizures, and generalized seizures. They can be given intravenously or by mouth. Long and short-acting formulations of tablets exist. Common side effects include nausea, vomiting, sleepiness, and dry mouth. Serious side effects can include liver problems, and regular monitoring of liver function tests is therefore recommended. Other serious risks include pancreatitis and an increased suicide risk. The drug is known to cause serious abnormalities in babies if taken during pregnancy. Because of this, it is not typically recommended in women of childbearing age who have migraines. My experience from Depilept, Joan, is to use it only for seizures and epilepsy management. I couldn't find any reliable literature about the weaning time for Depilept. It suggests that weaning off Depilept when having seizures could be an issue. Given that your dad has no history of seizures, the Depilept is just sedating him, that's all. Therefore, the sooner he can be liberated, the better. Does that make sense? Here is Joan's response. Hi Patrick, yes, this makes sense. I wondered if having a stroke is in and of itself a risk factor for seizures. However, they only said it was to stop the trembling, and again, he never had a seizure. Thank you so much. It unfortunately turned into a kind of conflict with one of the doctors who said he had all these years of experience and here we are telling him what to do. So your input is reassuring and helpful. I was there a few hours ago and saw that they have reduced the dose to 250 milligram twice a day for now. I won't be too concerned if he starts to tremble again. What I care about is figuring out why his awareness level has changed so much, why he isn't able to follow instructions like he did before. Thank you again and best wishes, from Joan. Hi Joan, I hope everything will turn out fine for you and your dad. Anyway, in regards to your last email where you say, I wondered if having a stroke is in and of itself a risk factor for seizures. However, they only said it was to stop the trembling, and again, he has never had any seizures. So, Joan, when was the last time they did a CT scan or a brain MRI for your dad? It is important for your dad to undergo such a procedure to determine what is the current status of the part of the brain that has been affected and what really caused the trembling. And if they're telling that it is not seizure, then what could it be, and that he has to be started with Depilept. Here are a few good points from reliable sources again. The NICE guidelines, and NICE stands for National Institute for Healthcare and Excellence, suggests to consider anti-epileptic drugs for a patient after a first unprovoked seizure if the patient has a neurological deficit or abnormality on brain imaging, which could be said to apply to stroke patients. Post-stroke seizures and post-stroke epilepsy are common causes of hospital admissions, either as a presenting feature or as a complication after a stroke. They require appropriate management and support in long term. Then you said it unfortunately turned into a kind of conflict with one of the doctors who said he had all these years of experience and here we're telling him what to do. So your input is reassuring and helpful. I was there a few hours ago and saw that they have reduced the dose to 250 milligram twice a day for now. Joan, conflicts amongst relatives of patients in ICU with the doctors are common, especially if the relatives are knowledgeable with what is happening to their loved ones. It is a form of self-defense for them, I may say. But after you said your point, which really makes sense, with the current appropriate management for your dad, later on the doctor for sure would realize that and do research too, as well as on his own. They may be experienced doctors, yes, but the appropriate care and management for specific diagnosis, especially for cases such as your dad, has significant improvements to aid in their recovery. And the way you communicate to them and share your point of view is very important as well. Based on the best available evidence, we would recommend treating the initial seizure post-stroke if it occurs more than 7 days after the event. We would suggest, after careful discussion with the patient or relatives about the risks and intended benefits of anti-epileptic drug therapy, treating with an appropriate first-line AED such as lamotrigine or sodium valproate for at least 1 year before considering tapering the dose. Joan, then you said, I won't be too concerned if he starts to tremble again. What I care about is figuring out why his awareness level has changed so much, why he isn't able to follow instructions like before. Joan, what are your dad's current medications? Depalept can cause sleepiness. Other medications will do as well. If your dad continued to have this trembling, I would be alarmed as to what might cause it. We need to rule it out and give your dad the necessary treatment and medication to control or totally eliminate it. Also, is the ICU team informing you about your dad's Glasgow Coma Scale or GCS? GCS is a neurological scoring system used to assess conscious level. What is your dad's current GCS score? How frequently are they assessing it? Any EEG? We need to gather these data. I hope this helps. Any questions, please let me know. Joan writes back, Hi Patrick, thank you for your incredibly helpful response. I have scheduled an appointment to speak with a prescribing physician tomorrow and will be much better prepared with what to ask him now. I will ask him about the factors discussed in the article that you sent me. Thank you so much. My father has not had any CT scan or brain MRI since about a week before he left the hospital, so probably not since the first week of October. They do not offer them at his rehabilitation center. He would have to be transported back to the hospital to have this done. The relatives who have guardianship are opposed to this option. I'm going to contact my neurosurgeon relative to ask about something he mentioned, a portable CT scan. The doctor that prescribed the Depalept actually said that if the family wanted them to stop it, they would do so right away. The conflict came about with the head of the department, who is renowned for his success in respiratory rehabilitation. However, by the way, his respiration has improved greatly in the last couple of days, though his eyes are closed almost all the time. Yes, communicating with doctors properly is a very delicate issue. Tomorrow, when I talk to the doctor, I will ask about my father's current GCS. From mid-October, when he left the hospital and went to the rehabilitation center, I have the following. I don't know if it's his GCS. Eye-opening 4, spontaneous verbal response 1, none. He could not talk with the tracheostomy tube, but he did try. 6, motor response, obeys commands. Score 11. What are his current medications? This is a very important question. I have the list and I will send it separately. Happy holidays and many thanks again from Joan. Hi Joan, we are indeed grateful that we are able to help you and your dad. Anyway, thank you for your response, and we'll wait for additional clinical information from you. Happy holidays to you and your family as well. But I also want to make another comment, Joan, and for anybody that has a loved one in a similar situation. The dilemma in this situation really is, as usual, families in intensive care don't know what they don't know. And what do I mean by that? They don't know what they don't know just simply by agreeing to send their loved ones to a rehabilitation center or to LTAC, also known as long-term acute care. Now it starts with what Joan describes here, dad's ambulance ride, which upset him, which was very tiring for him. And the reason I want to bring this up, you should not underestimate interrupting a care episode for someone that's critically ill, and anybody that is on a ventilator really is critically ill because they're on life support. So that's number one. Number two, when patients go from from ICU to a rehabilitation center or LTAC, their nurse-to-patient ratio goes down from 1:1 or 1:2 nurse-to-patient ratio in ICU goes down to 1:4, 1:5 in LTAC or rehabilitation centers, and sometimes even 1:8 or 1:10 overnight. Now, from my experience as an intensive care nurse, this is simply dangerous. Anybody on a ventilator needs a 1:1 nurse-to-patient ratio, because the risk of someone being on a ventilator dying without the specialist care of intensive care nurses around the clock 24 hours a day is simply too big. That leads me then to why they might have given the Depilept, because it has a sedative effect. Maybe they don't have the skills, and maybe they don't have the nurse-to-patient ratio to keep patients on a ventilator safe. One way to keep patients on a ventilator safe, especially if you don't have the skills and the numbers in terms of skilled nursing workforce, is to sedate patients so they can't, pull their tubes, can't pull the tracheostomies, and so forth. As always, the biggest challenge for families in intensive care is simply that you don't know what you don't know, which is why you should seek help straight away. You should contact us straight away when you have a loved one in intensive care, so we can guide you step by step through this experience. Also, you didn't know initially what medication your dad was on. Again, you should ask for medical records from day one. There's nothing that they should be hiding from you. So, and again, managing doctors and nurses in intensive care is very important, and we can help you with that. With any family in intensive care, you should be contacting us as quickly as you have a loved one in intensive care, so we can guide you, handhold you, and advocate on your behalf from day one. On that note, how can you become the best advocate for your critically ill loved one? How can you make informed decisions, get peace of mind, control, power, and influence quickly whilst your loved one is critically ill in intensive care? You will get to that all-important feeling of making informed decisions, get peace of mind, control, power, and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn quickly how to make informed decisions, get peace of mind, real power, and real control, and how you can influence decision-making fast whilst your loved one is critically ill or is even dying in intensive care. Your free Instant Impact Report. Sign up and download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn how to speak the secret intensive care language, so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions, discover the many competing interests in intensive care, and how your critically ill loved one's treatment may depend on those competing interests, how to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You will get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power, and influence in your situation. You will get real-world examples that you can easily adapt to your critically ill loved one's situation. how to stop being intimidated by the intensive care team and how you will be seen as equals. You will get crucial behind the scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also have a look at our blog section for more tips and strategies, or simply send me an email to support@intensivecarehotline.com with your questions. Also, have a look at our membership site, intensivecaresupport.org, for families of critically ill patients in intensive care. You can also call me, find phone numbers on the top of our website. Also, have a look at our ebook section, and you can also get one-on-one consulting and advocacy with me over the phone, via Skype and via Zoom and via email by clicking on the relevant tabs on the top of the website. This is Patrick Hutzel from intensivecarehotline.com, and I'll talk to you in a few days.